Okay, good morning, everybody. Welcome to the first live case, and we have a great esteemed chairpersons, and the live case is going to go from Apollo, Hyderabad. So, Dr. Manoj, can you hear us?
Not now. Yeah, they will say we are. Yeah, we can hear you loud and clear.
Okay.
Good morning, everybody.
Can we
Welcome
start?
to Hyderabad Valves 2022. Can you see us?
Yes, we can see you perfectly.
Yeah. With me, Dr. Daggubati, our friend, mentor, he is there. He is going to do the live case. Dr. Rufus is there, Sister Jamna. Anesthesia, Dr. Srinivas is there, and technologist led by Mr. Srinivas. So we'll start with the case presentation. Dr. Rufus is going to introduce the case. Slides, come. Slide.
Can you put down the lights, please? It's glaring.
Yeah. My patient is a 69-year-old male who is a diabetic and hypertensive, and he is an asthmatic for the last 20 years. He is on oral steroids for the last 5 years with multiple admissions. He had developed breathlessness, which was NOHA class 3 for the last 1 year. On evaluation, we found to have an severe AS. While evaluating for further, we found that he had a coronary heart disease, which is a double vessel disease. So he underwent PTCA to OM and RCA on 8th month of this year. His ECG showed a sinus rhythm with no bundle branch block. Echo showed a severe aortic stenosis with a mean gradient of 49 millimeters of mercury with mild LV dysfunction. His STS score is 3.5. His hemoglobin was 9.6 and creatinine is 0.6. This is his ECG, which doesn't show any bundle branch block. And this is the aortic gradient, which is have a mean gradient of 49 and max gradient of 78.
The most important aspect of any investigation in tower is multi-slice CT scan. And this is the multi-slice CT scan report of this patient, 3-Mencio report. The area is 392, area derived diameter is 22.3, LVOT dimensions are 23.3. Coronary heights are reasonably good, 15.7 on the left and 16.6 on the right. Sinuses of Valsalva for an Indian patient is quite generous. Yeah. Mild to moderate aortic valve leaflet calcium is there. We don't see any major calcium in the sinotubular junction or in the LVOT. Next. This is the annulus. It's little bit elliptical. The minor diameter is 19.8 and major diameter, if I can read correctly, is 25.8. Next. This is the picture for sinuses of Valsalva. You can see the coronary heights. Next. We can see the calcium mostly on the leaflets, and the implantation angle from S-curve is LAO 9 and cranial 10. Next. These are the pictures for peripheral anatomy. Good bifurcation, normal. There is hardly any tortuosity. Bifurcation is below the femoral head, and vessel size is very generous. There is mild amount of calcium on both the sides, but that's an adventitial calcification with sizes more than almost 7 plus. I don't anticipate any problem in this particular case. Next. We plan to use.
Next.
We plan to use a sentinel device, and we found that it's a bovine arch, which we can see a picture. Now, Dr. Ramesh will take over, and we'll start with a little bit talking about the sentinel, and then he will show us preparation and how to deploy it. Dr. Ramesh, over to you.
Thank you, Dr.
Go back
Manoj
to
and
previous
Dr. Rufus. I think this is very important to understand that there's severe aortic stenosis. The calcium score is not very high. So pre-planning is important. You don't need to do a BAV. And the annular area compared to LVOT and the sinuses of Valsalva, it's all very good. We can choose a 23 valve based on the annular area. And I think you won't be actually wrong with that. And
Okay, Dr. Ramesh, we have a great faculty over here. So let me start with Dr. Mehta.
Right.
What would be your choice in this patient? Would you go for a TAVI or would you go for a surgical valve replacement in this case? Because we have a 69 years old male who is a bronchial asthma and the coronary is stented previously.
Well, I had discussed this issue a couple of times. First of all degenerative diseases occur in Indian population 10 years earlier. The average life expectancy of an Indian is 67 years. A 72-year-old man may be considered as reasonably young in the Western literature or Western population. He is reasonably aged. Now, aging process and calendar age are two different issues. Therefore, the man may have an age of 70, but he may be very much aged. And I think in this particular case, I would consider tower an appropriate option.
Dr. Azra, what would be your valve choice in this case, looking at the case?
Straightforward case for TAVI, whatever valve you want to choose, you can choose. 392 is the perimeter area derived. 392 is the volume. It's relatively small valve. The access is good, not much of calcium. I don't think he needs a protection, but for teaching purpose, we can go for as a protection.
And Dr. Manitos, what do you think about using a sentinel device in this case?
Ramesh, in spite of sentinel use, 4 to 5% cases there is chance of TI, all the report shows. What your comment in that view?
Right.
More
I think,
important,
the protected tower.
more important is that, Amit, I want to ask you and everybody here, the importance of embolism protection device for carotid was the Sentinel. What is your overall concept about its utility?
So the Protect tab actually showed that it has no use, but we use seat belts every time, but 99% of time we don't need it for that 1%. But still, if we see the data, then we'll see that it has not made any difference in a small amount of stroke that goes on, but in large stroke, it makes a difference. But in this case, it's a bovine arch, number one. Number two, there is a lot of calcium in that innominate artery, I can see. So Ramesh, do you really want to use the Sentinel device in this case?
Yes, so you're absolutely right that that small strokes are higher in the Sentinel arm in protected tower trial that was presented at TCT recently. But however, the disabling strokes are lower in the Sentinel arm. So what it means to me is that people need to be trained properly how to use a Sentinel and not to really mess up in the arch with too much of rotation of the device. So I think anyone, in my opinion, younger patients should be given the benefit of Sentinel.
And what about your thoughts on using it in a bovine arch?
Amit, in the interest of time, I think in the...
We move forward,
Yeah,
Dr. Miss.
the bovine arch is a little bit challenging, so we will go ahead with the plan, and as we speak, we will take answers.
Yeah.
Your questions, I mean. So right now we have access on the left side, left femoral access through which a pigtail catheter is placed in the non-coronary cusp, as you can see. And left femoral vein, there's an access where the pacemaker is already placed in the right ventricular apex. And on the right side, we have an access with the 11 French sheath, and the 2 percloses are applied in the 10 and 2 positions, as Dr. Anil Dal said earlier. I mean, we would have chosen only one, but he has a little bit of oozing, so we chose 2 percloses. And now we have the radial sheath, that is for the Sentinel. So now we'll show you the Sentinel preparation first, and then we'll go with that. Zoom out, please. So it comes in this package that you can see, the plastic coverings that we remove. And here is a stylet. You remove the stylet first. And on this side, there's a, we're going to flush that end port, which will be coming from here. Okay, that's good. And tighten these valves that, no, not that one, yeah, light blue one. And this here as well. And it's very simple. You flush that one first. That's the distal one here. As you can see, that's good, and you can lock it. Okay. Now you can, I'll take the kidney bowl. You can remove this one. No, water.
It's okay.
So,
Ramesh,
so
if
then
you have
you
a-
flush that. Actually, you got, yes, sir.
Ramesh, if you have a small valve versus large valve, minimal calcium versus very severe calcium, no peripheral stigmas of calcification and atherosclerosis versus lot of calcification and atherosclerotic burden in the peripheral vascular disease. Would you think that makes a difference in choosing protections?
Okay.
Yeah, so yeah, at our center, anyone with a calcium score of more than 2,000, irrespective of the age, will get we are going to do a BAV, obviously bulky leaflets, they will get a sentinel. And anyone less than 75 will get a sentinel.
Yeah. The other thing is that if the
can pull
carotids
back
are
on number
highly
3.
calcified, or if you have a lesion in the carotid, then
Yes.
that itself becomes a contraindication for a sentinel device. We don't prefer
Absolutely.
a sentinel
And-
device in those cases.
Push it again, push it forward.
Most of the time, we also
Yeah.
try to avoid in the bovine arch, but I think it will be a good demonstration of
Yeah, so we are,
sentinel device in a bovine arch by Ramesh.
that's good. And now, so now we are captured the distal port, and now we're, this one, advanced.
Is there any
And now we're capturing the proximal filter. Pull back again.
No, I am not sure
What's your
about
question,
it.
sir? I didn't hear. Dr. Amit?
Is there any data on transcranial association, Doppler associations with this Sentinel device?
No, so there's no data on that. But the MRI is the only way that actually we could assess reduction of small strokes.
You
you
can
can
monitor
flush this one more
TCDs and you can see the hits, brain hits during normal TAVR. The number of hits, smaller hits on TCD is definitely much higher, but that does not translate into clinical strokes. It's a surrogate, yeah.
Lock it.
So if you see
now we
right
have
back in
you can load
2010
it
to
up on this.
2013, we used to see a lot of patients on MRI, functional MRI, used to have some defect, but if these patients did well, and that was the reason why all these kind of devices started being developed. But truly speaking, none of these devices in their, even in their first trials showed any kind of,
Okay.
you
Pull
know,
back.
benefit. Even the Clarier device went out. There are a lot of other devices coming up, which is, there is another device which covers up right from the innominate till the, you know, the descending aorta. But we don't know how these devices are going to
No,
fare.
only
Radial.
only
So
the arch
Ramesh,
and
can
head,
you
okay.
please keep on
Advance the wire, yeah.
telling us what you are doing?
Yeah,
So, that it
so
will be
we are
very
at, so you can see that now we are advancing the Sentinel over the Grand Slam wire. And so now we are ready with the proximal. You can use the proximal filter is right there in the innominate artery. And you can use the pigtail as a marker. So Dr. Manoj is going to deploy the number 1, which is the proximal filter. So I don't do aortic arch angiograms. I depend upon CT scans that are there. So then we have number 2 here. You separate it out a little bit, pulling back.
Hello.
Amit, if you have a right radial access which is denied, can you go for femoral 2 spiders?
I I have done a lot of cases with
You can do
putting,
that as well.
two spider devices. So in that case, what I use is
back
the
on
right femoral artery
Advance.
as the
No,
main
not
device, and then left two
Not yet.
femoral puncture I take
Okay,
up
now.
and down. And through these, I usually position the spider in right into the internal carotid. Yeah.
Okay. So we actually, in the beginning, before all these filters came, we used to put pressure on the carotids to see transcarotid pressure to prevent strokes back in 2009. So that I don't think did any good.
What is your anticoagulation protocol in these cases?
We have given 5,000 units of heparin, and ACT is 310.
Okay. How much? ACT?
Now latest, what is it? 337 latest ACT, just 5 minutes ago.
So Amit, it says
So the
392.
difficulty in bovine arch, as you can see.
So do you go for a supraannular valve or annular valve? Because both valves can work.
So if you look at the studies, the study says that if you are using a 23 millimeter and above, anything is good for you. But 23 and below,
let's concentrate on
does better than the annular
bovine
valve.
arch issue. Let's concentrate on the bovine arch issue. So after how much time you will
Yeah.
feel to
So
do a angiogram? I
Yeah,
think-
now
yeah.
we're getting ready for that as well. Be gentle,
So
don't
that's the
really do
difficulty with the
any
bovine arch.
aggressive, yeah.
Because when you make a bend on that distal portion, usually the wire, negotiating the
15
wire
mm,
into the
15,
carotid
right,
becomes
well.
really difficult with the bovine arch.
Right. So sometimes
So,
we just left one
Ramesh-
filter at least thinking that it may be, yeah.
Ramesh, what about putting the coronary wire directly into the left carotid and then deploying the proximal filter and then the distal filter? Would you think that as an option?
It's possibly that's true. It could be done as well, you know.
So you ask the patient to
Are we
take
ready to
deep
inject?
breath.
Yeah, we are ready to
deep
inject.
breath. That will stretch and can alter the angles of the bovine arch.
Yes.
Now there is a attention deficiency syndrome. Like if you pay your attention to things which are not necessary in complex angioplasty or structural heart disease, your main attention to the main thing will also get diluted. For example, if you're spending a lot of time in putting a filter there, then your attention on the valve also
Right.
get diluted. For the beginners, for the expert, it doesn't make a difference. So choose your technique or your, strategy beforehand. So that I'll be spending 5 to 10 minutes on.
Yes.
So, Dr. Mehta, what do you feel
So
about?
let us know if you are.
What do you feel about the time we take for positioning the sentinel device in a bovine arch?
So that's what we are talking about, and I think Dr. Hazra also said that if it's taking too long, after 5-10 minutes, you just abort that and protect at least one vessel, and move on with the procedure.
Amit, first of all, the incidence of cerebral embolization is highly, highly underestimated. It's not like there have been people, the neurologists who have been assessing the comprehensive function and the parietal lobe function, and says the incidence is embolization is as high as 40%. Question is, are those devices capable and their ports are capable of preventing minute atheromatous embolization, which might be taking place from ascending aorta rather than from the valve? And that this is the issue. So I, for one, we have not used many, a couple of times, but I feel that
Right.
this is necessary in only few selected circumstances.
Dr. Mehta,
We'll change the
perfect. Hardly 8 to 10 minutes extra time needed, number one. Second thing,
Give me a
the embolus, atheromatous plaque or debris and calcium, or even some myocardial cells also may embolize. But in our country, the chance of embolism is less because calcium plaque is so much less. Of
No,
course,
just a
some
little bit more
definitely
over the
selected
arch.
cases must be used
to make
when the particularly tortuous artery, severe calcium artery, definitely there's enough utilities there. Cost not too much high.
No, this we have not changed.
So, Ramesh, you have positioned
Oh,
the
okay, no.
sentinel in the subclavian and the innominate.
Well,
Absolutely.
Amit, there is a
Right.
question
So
from
proximal innominate and the distal filter is in the subclavian to prevent embolization at least to the vertebrals, right? So as you said that don't really break your heads over it. Protect some vessels, intravascular, intracerebral vessels is better than nothing.
So this is the usual
We are going to
difficulty that
exchange
we
now the large sheath.
So this is the difficulty that we face in bovine arch. So while you do a bovine arch, the last sentinel I put was in a bovine arch. So what I did is I directly went with the wire into the left carotid, deployed the proximal device, and then subsequently pulled back and deployed the distal device. Dr. Manoj, can you keep on continuing telling us what you are doing so that for the audience it is going to be...
Can you look at the sheath? Now we are removed the 11th sheath, and we are going in with the large sheath, which is the Python sheath.
it's on extra support wire. Yeah.
An extra stiff amplats wire that is placed over an AL1, and as you can see, we are following on fluoro.
Can you
to
change
make
the
sure
mic
that
over there so that we
problems.
can
Hello. Yeah. Is there any adverse data as far as the sentinel device is concerned if you have significant calcium in the aortic arch?
So that
I
has
have to
always
change the
been,
mic. Ramesh,
you
mic
know,
is not audible there.
exclusion criteria in all these trials. So we don't know anything about those extensive calcium because all these people have been excluded from the trial.
Teflon wire.
The sentinel can protect 3 vessels. If you really want to protect 4 vessels, then perhaps the brachial hyperemia. What is brachial hyperemia? If you put a blood pressure cuff on your arm, and during implantation, you suddenly release. Suppose you press it for 5 to 7 minutes. If you release it, there will be sudden hyperemia in the left upper limb. So that can drag whole blood in the left arm. This is developed in Israel and Turkey. Some scientist has published a paper. But in this case, he has put the sentinel in the subclavian. So 1 carotid is not protected. So max to max 3.
Yeah.
Well, ready?
And honestly, I think
So
the anatomy is such that the maximum embolization usually takes place from the right carotid artery. Right carotid.
Right.
So,
One injection.
yes, the majority
So
of the embolization.
Dr. Mehta, that's a good point.
Actually, the right carotid artery is protected because of the innominate. So,
Okay.
Yeah.
Okay.
Angle
okay,
as well.
so now they are going to cross the valve.
I agree with the comments.
Amit, can you hear Dr. Ramesh?
Can you hear me?
Yes, of course. Ramesh.
Okay. Okay. So we are about to cross the valve. We have taken an AL1 and a Teflon 3-2 wire, straight tape.
So, as I think earlier we were talking about protection of all the 4 vessels. There is a trial that's going on called MBlock. It is going to
Excellent.
look
As you
at
can
the
see,
MBlock device versus Sentinel device.
Dr. Ramesh has already crossed the valve, and you can see as soon as he crossed the valve with the wire, he did not push too much on the apex of the ventricle, but instead he pulled back and just then pushed back the catheter. Now he is using the exchange length.
Yes. That's very important.
wire.
You don't want the AL1 to go towards mitral valve.
And then we have exchanged with a soft wire, 3-5 exchange length, normal regular wire. Now we are going to take a pigtail, place it properly in the apex, and then the pre-separated wire, Safari extra small, will take it.
Ramesh, do you have any experience with OptiSense wire, the one wire solution for everything, pressure, the crossing, and the safety? OptiSense.
No, I think I don't have any experience. If it costs me more than whatever the wire that I have, I'm very cheap. So I use the same wire. Normally, what we are trained with is Amplat's straight
Hemodynamics.
and then exchange with an regular wire to exchange with the pigtail. These are the steps that nobody should be missing it. And again, make sure your catheter is at the apex before you exchange with either confida or a safari wire.
Hemodynamics.
So, Dr. Sumanta, what do you think, what is your usual view to see whether the catheter is in the apex or not?
RAO?
Yeah.
Okay.
But this is in.
Go to
Okay,
RAO.
as you
RAO?
RAO is the best view to see whether the catheter has gone into the apex or not. Nice way to actually, after you take the AL1, if you want your wire to go into the apex, then what you do is you give a small clock, pull back the AL1 and give a
Fluoro
small
that.
clock, wise turn, and
Fluoro
then go
and
with
go
the
back
wire.
to
What do you
LAO?
feel about this
Or a deployment
idea,
angle.
sir?
Where?
LAO 9, cranial 11.
LAO 9, cranial 11.
Dr. Rohit, any
back.
comment you would like to make?
So as you saw that we went into RAO to position our wire, we were confident that the safari was in a good position.
Dr. Samir,
I mean, the pigtail was in a good position and exchange for a safari.
so this is which safari, small, large, medium?
Extra small.
Extra small. And the valve is prepped and loaded, and you can see that where the skirt is on the aortic side.
So
That's okay.
Okay.
Amit, we have Safari, M plus extra stiff, Confida, M plus super stiff, and finally Lunderquist. How do you decide what do you want to use?
Safari is a good wire. It comes in 3 sizes. It's a small, medium, and large. Depending upon the size of the ventricle, you can choose
40
the
millimeters,
wire.
and the
If the
sedation,
ventricle is
and
very,
50
very
on the
hypertrophied, you
ingredient
go
of
with the
it.
small.
Valve
If
area is
you got a
0.6,
good
0.7
size, you go with the
on the
medium
echo.
or the large. Confida is a
the
good
ED
wire.
sure.
And if you see the strength of Confida and Safari, they are almost the same. Lunderquist double curve is an excellent wire, but you should be very careful about positioning in the apex because you could actually perforate the apex. And if you have a very horizontal aorta, if you have a very small femoral, if you have very calcified aortic valve, then you can go with the Lunderquist wire because that helps in stabilization, that helps in crossing the valve. Particularly if it is RNN fusion, then my go-to wire is a Lunderquist wire. Otherwise, 99% of the time you can do it on a Confida wire.
Dr. Ramesh,
Sometimes when the opening
I
is very
recommend
eccentric.
going with the Lunderquist for 34 millimeter valves. That's what I do, at least in our practice, especially with the Evolute FX. You don't need Lunderquist for 26, 29. So I changed that. I used to use Lunderquist for all. Now I switched back to Confida for 26, 29 valves for the self-expanding and go with Lunderquist for 34 Evolute FX systems.
Dr. Ramesh, your choice
So
of
we are
ball
crossing
and the
now, as
reason
you
for
can
the
see.
same.
Choice of valve, because he had coronary artery disease and he is a 69-year-old, there is probably likelihood that he might develop worsening of coronary artery disease, and so coronary access is also important, and that's the reason we chose balloon expandable in him.
So I would like to ask the panel what they feel about the choice of valve and the coronary access.
Yeah.
Dr. Mehta?
It is not always true that when you use a balloon expandable valve that will be able to protect coronaries. I go by the CT anatomy that I have. If the sinuses are large, then I would not be worried too much about the coronary heights.
Pacemaker.
But if the
100.
coronary heights and sinuses large and the
will
coronary
go
heights
to
are
180 then.
favorable,
That a
I
short
wouldn't
run of
wouldn't
180
matter
is
to me.
okay.
100.
By the way, people have submitted many papers and work has been done about the access of the coronaries
Good.
after the transcatheter aortic valve replacement. And I think this issue will be coming up more frequently simply because
180, 10.
delayed coronary obstruction is not a small issue. We have to still see.
110.
And delayed coronary obstruction with variety of causes, etc., is likely to compel, and as you rightly said,
No,
that
that's
if you are going to treat low-risk
Come down,
population, low-risk people,
No, no.
the low-risk people by
9.
far largely young people also. And therefore, the coronary
LAO
problem
9.
is going to be faced by all of us. And I think, therefore, a careful selection of the valve at the time of the procedure,
LAO9.
keeping in mind the coronary heights, the sinuses, and approaches, I think is important. In this particular case, I think even self-expanding would be also quite okay.
Your opinion?
Yeah, the first cut in human
So,
body is the deepest
Yeah, we're
cut.
going.
The first cut is the deepest cut. For everybody should remember, whether you put a stent or a pacemaker scar or the first valve. Now, if you have a coronary problem in the future, balloon expandable valve is the best. Not only that, in lifetime journey of valve, like if you need another valve, if you have first valve as a balloon expandable, then you can put another valve like balloon on balloon or balloon self-expanding on balloon, much easier than having a self-expanding valve than having a balloon expandable valve. The first choice should be balloon expandable valve, except if it is very large annulus, like 34 millimeter evolute, or very small annulus, when you have a supraannular valve, where the valve area achievement will be little higher. So remember, first cut is the deepest cut,
Dr.
Very
Hajira,
well
one
whether it is
thing-
lab or the valve.
Dr. Hajira, one thing I meant
Ramesh,
to
I think you
mention.
are ready to go inside with the valve, so let's proceed. I
Right.
think.
Yeah.
I have a definite
Thank you. I
opinion
think
regarding
all
the
excellent
coronaries
points,
because
Dr. Hajra.
in coronaries, I
Okay.
think all the valve accessing the coronaries are difficult. At the end, you should learn how to access it.
Amit, one thing, you have to believe the valve design matters.
Zoom in
Number
on-
one, if you follow the bridge suspension concept, you see height is more short angle,
Zoom in.
or the height is short and the wide
Can we-
angle.
can we
So
please
that
con-
is the
Yeah,
things
that's good.
responsible
Can
for
we
so
please
many
concentrate on
complication
the
of the valve.
procedure?
That's good.
Can we please concentrate on the procedure now?
Yes, yes. So yeah, as you can see, we crossed the valve. We placed that slightly less radio opaque in the pigtail marker. Okay. And so the mid marker is above the pigtail, as you can see. We're going to take a picture here. Okay.
Picture.
Inject, please. Okay, that's good. I like this placement. This will be giving us a 90-10. Okay. So we're good with the pacemaker. We check the pacemaker, and we check the ACT is more than 300. We'll be pacing at 180. I'll tell you, not yet. I'll tell you. Okay. So now pacer on at 180.
Pressures are
Okay.
going down.
Inject, please. Okay. Inflate. Slowly and slowly. Yeah, go up. Commit now. Push it
Pull it.
all the way. Okay. Deflate. And pacer off.
Good.
Okay. Slowly pull back.
One.
Yeah, the valve is in good position. Good.
You want an injection? No.
We'll take another picture to show you that. And can you bring it a little bit caudal? More caudal? A little bit more caudal? I like to take the picture with the parallax out, okay?
Yeah, that's the usual. I think
Okay.
everyone
So the
of us
wire is
does
still
the same
in, so
thing.
we'll. Right. Okay. We still have the wire, but I'll take a picture. Inject, please. I think that's from the wire, I guess. Take it out. You can remove the wire. We can.
1 minute.
You want to get hemodynamics? And
Yeah, just BP, source BP.
I think we can remove the wire and take a picture because
Just resuscitate him. Give some NORAD.
Yeah.
Yeah.
The blood pressure like 80, 90, picking up. Okay.
Yeah, it's
I'll
coming.
take the picture.
Hey,
Let's
ये निकालो ना pacemaker. ये pacemaker निकालो ना यार.
Okay. So patient's heart rate is 62. He has a little bit of wide QRS still. We'll wait and see how he does.
Picking up.
the valve is quite high deployed, so I think that QRS is going to get narrowed over a period of time. So nothing to. So
Right, yes.
what is the blood pressure at present? I can't see because.
100 by-
98 or 51, and it's climbing up.
So for the audience, Dr. Ramesh, you deployed in a globe planar view or the what is called as cuspal overlap view? And what's your choice?
Yeah, we went with the coplanar view for the balloon expandable. Ideally, you could do both. You could definitely go in a cusp overlap as more data is coming up, even with balloon expandable, that it is probably not a bad idea to go with the cusp overlap, you know.
The commissural alignment, you know, you have the new valve from the my valve that got octagonal, the helix. What is that?
So octocore is the new valve from Merrill, and what they have done is they have gone from hexagonal to octagonal shapes, and if you see, the diamond actually overlaps in that. The advantage, what the company says, is that the valve force shortening is very less. So you have a controlled deployment, and actually, wherever you place the valve, you end up getting the end result there itself. So you know how high you are placing the valve. And so they claim that the pacemaker rate is lower in these patients. So is this the...
So now with the short run of noradrenaline, blood pressure went up.
So this is the...
So we stopped the noradrenaline and...
my valve, not the octocore. Yes. So Dr. Ramesh, I think we can take one picture, last picture.
Right. We just, did you see the hemodynamics? There's no gradient now?
Yeah. Yeah, there is no gradient, and LVEDP, but seems to be quite high. I don't know why.
Yes.
So we can take a picture and see. Oh.
Right. Yeah, but the diastolic pressures are still very good. And
100.
Yeah, diastolic pressure is really good.
Is it neurologically stable?
Could be the LVEDP because of the coronary, previous coronary problem as well. So we can take a picture and we can decide what is the cause.
Okay. Sure. Ready to inject? Okay. Inject, please.
Oh, that's an excellent result, Dr. Mes. Congratulations on that.
Yeah, good. Yeah, the heart rate is now back to normal sinus rhythm with 50 heart rate, 52, and the narrow QRS. We are now going to show you how to take out the sentinel, because don't give any protomin before the sentinel. Okay, can you show the arch, please? And so again, in the arms here, you can show this. So first thing is to capture the distal one. So number 3. Okay. So then you collapse number 2, which is introduce it back and counter. So then you have to do number 1, which is the proximal filter capture. Do it slowly. The reason I'll tell you is that one of our centers, they were doing so fast that the wire, which was a Whisper moderate support wire, got caught onto a self-expanding valve and really pulled out the self-expanding valve, causing aortic dissection. No need to rush here. All the steps need to be done very slowly. And once you capture number 1, keep your thumb on the 1, and then remove it through the radial sheath until it comes out.
That's the most important point that he pointed out. Is there any question from the audience regarding the case? Otherwise, we had an excellent case and a good demonstration about putting the Sentinel device, good demonstration about where the positions to be and how we can position the valve high. So thank you so much, all the panelists. If the panelists would like to ask any question, otherwise we would like to close the session. And thank you. In excellent case demonstration, Dr. Manoj and Dr. Ramesh.
Thank you very much.
Thank you, everyone.
Thank you. Thank you all.